Okay, so today we'll tell you how to join ESBICM online classes. Once you open up the website esbicm.com, you will get this sort of page. Go to learning resources, click on online classes calendar, and once you click on online classes calendar, this calendar will show up. Now, in this, we have listed our online classes schedule, and once you hover up any class schedule, you will get to know the topic of this class, you date, time of that class, and also the joining link is also there in the class details. So anybody from anywhere in the world can join this class. Limited seats are there, so make sure you join on time. Thank you.
Yes.
Okay, we'll start today. Welcome to ESBICM Weekly Classes, and this week we are discussing the topic of meningitis management in the ICU. So today's topic will be taken by Dr. Benjamin, who is a critical care fellow in our team. So we'll be discussing the practical aspects of meningitis in coming 20-25 minutes, and then we'll can take few questions if the time permits. Okay, Dr. Benjamin, you can start.
Good. Thank you, sir. Welcome to all. Good evening for this weekly ESBICM classes. Today we'll be discussing on about meningitis, and in a broad sense, we know that there are two types of infection of the cranial contents. Firstly, the infection involving the brain meninges, which is called meningitis, which we're going to discuss today. And secondly, the infection of the brain parenchyma, which is called encephalitis. If we come to the definition of meningitis, it is the inflammation of the brain meninges and the subarachnoid spaces, and it can be caused by various organisms. It can be bacterial, viral, protozoal, tubercular, fungal. So all these can cause all these organisms can cause meningitis, and other than that, it can be caused due to subarachnoid hemorrhage or many neuro surgery patients, post-op patients is seen of this. And there is another term which we see when we read the book, aseptic meningitis. It is the most common. It is when the bacteria cannot be isolated in a meningitis patient. So all these things is a general overview, and today we'll be looking at how to approach the patient with.
Okay,
Before
so
we approach further,
you mean to say that
yes.
the meningitis can be infectious, can be non-infectious. So one majority of them are infectious, but you should always consider the non-infectious causes of meningitis, means inflammation of the meninges, which could be seen in subarachnoid hemorrhages and aseptic meningitis also.
Yes.
Okay, thank you.
Yeah. So before we proceed further, there is a quote which I read in one of the books. It says, why this individual in this place has developed this disease at this time. It can be applicable for every patient and every disease, but I wanted to share this. This gives us a better approach towards each patient in our day-to-day working life. So with this question in mind, we'll approach the patient. So we'll just look at the causative organisms also once. Bacterial meningitis, most commonly caused by Streptococcus pneumoniae and Neisseria meningitis. Earlier, before vaccinations and all, we used to have Haemophilus influenzae, which was the most common cause. But now it is Streptococcus pneumoniae and Neisseria. Viral meningitis, we know it's enterovirus and herpes simplex virus are the most common. And encephalitis is enterovirus, herpes simplex virus, arbovirus, and West Nile virus, etc. There are a few more organisms. This is the algorithm for the approach towards a meningitis patient. So when a patient comes to us in the ER or in the ICU, first we see the clinical picture. Is the clinical picture in any relation with a patient with infection of the cranial contents or CNS infection? So in the books we read there's a triad: fever, headache, fever, neck rigidity, and altered sensation. It is not necessary that all three will be present in the patient, and it is also important to note that if none of the three are present, then it is very less likely that it is a meningitis patient. So these are the clinical pictures, and in around 50% of the bacterial meningitis patients, 2 out of 4 of these symptoms 4 means fever, headache, neck rigidity, and altered sensorium. So 2 out of 4 will be present in almost 50% of the almost all the bacterial meningitis patients. So these are the clinical picture which you will get. And if this clinical picture you have received in the ER and this patient has come to the ER, we think about, is there any indication for imaging? Indications for imaging, as you can see in the footnote itself, is there any old cerebrovascular accident, any CNS disease, any recent seizure, any new focal neurological deficit, or any other altered level of consciousness? Is there raised ICP? Raised ICP can be seen by, there can be seizures, there can be new focal neurological deficits. The patient might be having papilledema, GCS less than equal to 12. So all these can give us an indication that this patient requires imaging. And why is raised ICP an important indicator for imaging? Because such patients may be having an underlying cerebral mass lesion or the malignant edema in the cerebrum. And if we do a lumbar puncture without the imaging, it may cause brain herniation, cerebral herniation. So it is important to go for imaging. If there is no indication for imaging, we move forward with blood culture and lumbar puncture and start off with the antibiotics. If there is indication, if you see all these factors and you think that this person should undergo an imaging, then first thing, before the imaging, before anything else, we have to send blood culture and we have to start antibiotics. The treatment of the patient, the antibiotics, there should not be delay at any cost. We want to, the later we start, the more delay we cause, the poorer the prognosis. So it is important to start off with the antibiotics and then we do the imaging. If there is no contraindication to lumbar puncture, we do the lumbar puncture. We then accordingly CSF findings and CSF culture, and accordingly we manage our treatment. If there is contraindication, then we continue the treatment without the lumbar puncture.
Okay, so
then once we have done
sorry to interrupt. Those who are listening, whenever you read septic guidelines, there is always a line written that you send the blood cultures before administering the antibiotics and then initiate the antibiotics within 1 hour. Meningitis or neuroinfections is the only indication where you don't have to wait for any investigation, whether it's imaging, whether it's a blood culture. You suspect meningitis, straight away push the antibiotics into the patient, because the more time you waste, the chances of getting the patient deteriorated is very high. So it's really an emergency, and if you suspect, do push the antibiotics even without imaging or any sending blood cultures. Okay, Dr. Benjamin.
These are the CSF findings which will help us to differentiate between the different types of meningitis. Mostly we'll look at the bacterial and viral in this. In a very general sense, if we talk about it, the WBC counts, the white cell counts in bacterial is very high, can go up to 20,000, 100 to 20,000. And it is primarily consisting of polymorphs. And if we come to viral meningitis, it is not very high, it is 5 to 500, and primarily lymphocytes are present. And so this is a good indicator as to which type of meningitis we are dealing with. And we can see the proteins and glucose and the gram staining also. And once we get an idea, if whatever CSF routine microscopy reveals, we have to send it for culture, and so that we can isolate the organism which is dealing, and the treatment protocol can vary according to the organism. Also, remember to store one sample, because we may have to do some more investigation on the the lumbar puncture sample. And after that, there are few more investigations.
Can we go back to the CSF slide?
Yes.
So those who are listening, a few points, important points, which can give you clue by looking at the CSF. Firstly, if you are treating with a bacterial meningitis and the patient has not received any antibiotics before, usually their TLC counts, means the bacterial neutrophil count in the CSFs are very high. They are more than 500, 1000. They can be there and mostly neutrophilic. But if this patient has received previously some antibiotics in some other hospital, so there you can have a patient with bacterial meningitis, but it may be possible that you don't find so much high total count in the CSF. So we consider them as partially treated bacterial meningitis. Now the confusion arises in this scenario. If it is a partially treated bacterial meningitis, then your viral meningitis markers can mimic. In your viral CSF also would be like this as of partial treating bacterial meningitis. So few differentiating features are, in viral meningitis, there is also simultaneously encephalitis, is the inflammation of the brain parenchyma also. So patient may have neck rigidity, fever, headache. Other than that, patient may have more component of altered behavior, altered sensorium. Also, in viral meningitis, you have a slightly predominance of lymphocyte, means lymphocytes will be somewhere around 40%, neutrophil will be somewhere around 60-65%, versus in bacterial meningitis, the neutrophilic count is little bit higher, somewhere around 70-75%. So these can give you history, clinical findings, and the differentiation of total leukocyte counts. They can give you an idea that what we are dealing. Also do see the protein. What is the protein? It's usually high in the bacterial ones and more equivocal or non-conclusive in viral, fungal, or tubercular. Fungal you can have a little high. Glucose, yes, in bacterial meningitis, because they consume bacteria. So blood CSF versus blood versus CSF glucose difference will be more than 0.6. Suppose you have 100 sugar in the blood, you will have less than 60 in the CSF. So this gives you clue it's a bacterial one. Always do a corresponding sugar along with the CSF and mention in your notes that this was the sugar at the time of CSF. Because if the lab gives you the glucose finding, it will be very difficult for you to compare whether it was 1 hour before sugar or 1 hour later sugar. So these are few things which help you to differentiate between the CSF. Anybody who has any doubt, they can ask in the comments. We can move to next slide, Dr. Benjay.
Sir, 1 minute, sir. That last thing you told about that blood glucose and bacterial glucose, I could not get it. Sorry, sir.
See, what happens whenever there is an infection in the CSF, they consume the glucose. So the equilibrium between the blood sugar levels and the CSF sugar levels will be disturbed. So suppose your blood sugar levels are 100. So if you have infection in the CSF, the glucose will be consumed and you will have a less sugar, especially in bacterial meningitis. So the ratio, if it is less than 0.6, means if you have 100 sugar in the blood and the CSF sample comes and the sugar level comes 50 in the CSF, then it's okay. A more indicative of a bacterial sort of meningitis infection in the CSF. That's what I'm saying. So whenever you do a CSF, always check the corresponding sugar and mention in your notes that we did a CSF and the corresponding blood sugar was this at this time. And when the lab do the blood sugar in the CSF, they also report this was the sugar in the CSF. So by that ratio, you can have an idea what is the ratio of sugar in the CSF at the time we did the CSF number. Got my point?
Okay, sir.
Okay.
Yes, sir.
Okay. Yes, Benjamin.
So the other investigations which we can do, as discussed earlier itself, brain imaging, blood culture, and we should do, if the patient is right now in the ER or in the ICU, so we should do CBC, clotting profile, biochemistry, chest X-ray, ABG to rule out any other systemic infection. And many times the source is through infected ears or sinuses, so those should also be examined. In the management area, we usually start off with be it empirical, be it bacteria, according to the bacteria, according to the bug. Broad spectrum antibiotics we start, and steroids. We'll be discussing the antibiotics in a later few slides. Steroids have a controversial role. They have a good role in pneumococcal meningitis, streptococcus pneumonia. Otherwise, in other bugs, steroids don't play a significant role, and therefore the International Infectious Disease Guideline says that steroids should be given in pneumococcal meningitis. Other than that, it should be avoided. And usually we give dexamethasone, and we'll be discussing that also in the coming slide. Other management can be like if the patient is presenting with seizures, we can start off with IV benzodiazepine, then give phenytoin or levetiracetam. And in a patient with GCS less than 12, and as discussed earlier, most of the bacterial meningitis patients may require almost 50% of the bacterial meningitis patients will require endotracheal intubation. So endotracheal intubation is in a patient with GCS less than 12 is indicated, and endotracheal intubation. And ICP monitoring is also important. If the patient is on ventilator support, we can hyperventilate the patient. If not, we can start off with mannitol infusion. We can give CSF drainage. We can place an external ventricular drainage, or we can do serial number punches to relieve the ICP, the intracranial pressures also. And other management supportive like physiotherapy and prevention of pressure sores is also important.
So here I would like to just go back to slide, the same slide, yes, just to that slide. So what here those who are listening need to understand that you can see the endotracheal intubation is recommended in books if the GCS is less than 12. Usually in the trauma protocol, this is less than 8. When you have a GCS of less than 8, then you intubate. Why it is the threshold is low in meningitis? Because of two reasons. One is usually because of neck rigidity. These people are not able to maintain their airway so nicely as a trauma patient. So for maintenance of the airway, you should keep a low threshold and you intubate early. Secondly, if the patient is not able to maintain the airway and he is suffering from meningitis, then there is chances of, because of coughing and all those, the chances of raised ICP are high. So that's why the threshold for intubation in such patients are less as compared to a routine trauma protocol or other ICU patient. Secondly, regarding broad spectrum antibiotics, you should have a clear idea which antibiotics penetrate the blood-brain barrier. This is very, very important because at times your culture reports can come in which the antibiotic is in vitro sensitive, but that drug is not able to penetrate the blood-brain barrier. So that antibiotic will become useless. So from every group, you need to understand which antibiotics can penetrate the brain. Also, you have a slight blessing in disguise that during the infection, blood-brain barrier gets disturbed a little bit. So some antibiotic reaches the brain. If any antibiotic you give, it can reach the brain, but you should give those antibiotics which have a higher penetration in the CSF. That's very important. So these are the things. We can move to, let's discuss the antibiotic part.
Sir, there is one question, please. Sir, is it recommended for all type of meningitis or only we are talking about bacterial meningitis that GCS is less than 12? It's recommended that endotracheal intubation should be done.
Any meningitis patients, and meningitis means inflammation of meninges. So inflammation of the meninges can be due to anything, due to infectious cause, non-infectious cause like subarachnoid hemorrhage. It can be due to bacterial, viral, fungal, and all these things. So the idea here is you need to assess on a case-to-case basis, and what they are trying to say is your threshold for intubation should be less. Any patient who is suffering some inflammation of the meninges due to any cause, because that fellow will not be able to maintain the airway, and also the chances of raised ICP will be high, which will further deteriorate the condition in such cases. Okay?
Yes, sir, got it.
Okay. Yes, Benjamin.
So coming to the antibiotic therapy, empirical therapy, as discussed earlier, hit early, hit hard. The earlier you start, the better the prognosis. And we give IV third generation cephalosporins. We start off with ceftriaxone or cefotaxime, 2 gram BD, 12 hourly. And in case a patient has come from a very pneumococcal resistant area, and we should add IV vancomycin 10 to 15 mg per kg 8 hourly according to the renal requirement. And as I said earlier, again, DEXA or steroids should be started for pneumococcal meningitis, 0.15 mg per kg 6 hourly. And if a patient is more than 50 years immunocompromised, we have to add ampicillin or amoxicillin 2 gram. And if we are suspecting, this is empirical therapy. So if we are suspecting that this is viral meningitis, we should add IV acyclovir 10 mg per kg for 8 hours. And if we have center cultures, we get the organism as Streptococcus pneumoniae. Then we give ceftriaxone, and if the penicillin MIC is more than 2 microgram per milliliter, then we give vancomycin and ceftriaxone. In case of Neisseria, we give ampicillin and ceftriaxone. No steroids in Neisseria or Listeria. Listeria, we give ampicillin, and if there is penicillin allergy, we use trimethoprim sulfamethoxazole 5 mg per kg 8 hours. And then for viral meningitis, we use supportive measures. It usually heals on its own. It improves gradually. So we have to give supportive measures and analgesics and bed rest. If we find that the organism is herpes simplex or varicella zoster, we add acyclovir. And encephalitis, as such, we are not discussing, but just mentioning herpes and encephalitis, we give IV acyclovir, and other viral encephalitis, we give supportive measures.
Okay, so here a few points need to be understood. That this is, as we have discussed, this is the only condition where you need to give the antibiotics before even sending blood cultures or before doing an imaging. So giving right antibiotic at the right time, which can penetrate the brain, is very, very important. So you have mentioned that if the penicillin MIC is less than or more than a particular value, you can change the antibiotics, but usually the MIC levels comes on the second or third day. So what we practice in our ICUs is we start empirically with ceftriaxone 2 gram BD in most of the cases. Now, if you are receiving cases in your ICUs, or you are having a local, your unit or local area flora is saying this meningitis is due to resistant organism, you can straight away start with antibiotics, high antibiotics like meropenem and other stuff. Vancomycin needs to be given. Of course, the monitoring, drug level monitoring, is not available in each and every setup, but you can have a vancomycin. You can give vancomycin, but make sure you are hydrating the patient well, and you can monitor the creatinine levels and renal functions. One more thing, while giving vancomycin, it should always be given over a period of 1 hour, because if you give it fast, it can develop Redmond syndrome. Those who are listening should also review the guidelines to treat nosocomial meningitis or nosocomial encephalitis, because the dosages of broad spectrum antibiotics are further high in those patients. So if maybe you have a patient of stroke, CVA, which have intraventricular bleed, and then you have put a EVD in that particular patient, and now on the third, fourth day develop fever. So it's a nosocomial meningitis. So the drug of choice will be very different. You need to cover broadly resistant bugs, and also the drug dosing will be high, will not be the same as compared to the community acquired meningitis. It will be higher in nosocomial meningitis. So this was in short about meningitis management in the ICU, which is very nicely presented by Dr. Benjamin. So point is, identify clinically headache, fever, altered behavior, neck rigidity, these will be the some signs present. If you suspect, start antibiotics, do an imaging to rule out whether it's a raised ICP. If there is a raised ICP, doing a lumbar puncture can herniate the patient, and the patient can collapse during the doing CSF. So imaging is must. Even a plain CT would suffice just to, if you want to see the raised ICP. Secondly, after antibiotics, the supportive management will be airway management and all other stuff. One more thing is fever should be deliberately controlled. In sepsis, we say that if it is more than 101 fever is there, then only give paracetamol to control the fever if it's compromising the hemodynamics. But fever is very, very detrimental in neuro patients. So even a spike of 100 is not good. So you should maintain the temperature of the body around 99, less than 99. You should give paracetamol and close cold sponging. The other thing which hampers the recovery of such patient is hyperglycemia. So these patients should have a glucose control somewhere around 150 to 180, slightly liberal control. So this should be monitored closely. Even if you have to do 4-hourly sugar, do it. Even if the patient is not diabetic, monitor the sugar. These things, few things are very, very important. If the patient is in the extremes of ages more than 50 and kids, you should always think of listeria, and ampicillin should be added in such patients. So these are the with the practical aspects. You can read O's intensive care manual and Washington manual of critical care. You can get a better idea, and the algorithms are there. Now, anybody who wants to ask some questions, you can ask here, or those who have not seen this during live session can ask in the comments or on the forum.
There is one question. Suppose I received a patient, 48-year-old male, with all the signs and symptoms of meningitis. Sir, yet we have not got any report, lab report. We are any lab report is not with us. So what should be the line of treatment at that moment? In ER, I'm talking about.
So whenever you talk about the ER, AVC comes first. You should take care of the airway, breathing, and circulation. That's fine. If patient is shock, give fluids. Secondly, most important is start with empirical antibiotics. You should start with usually ceftriaxone 2 gram 12 hourly. You should give 2 grams there, and then go for imaging, and then shift to ICU. And there will assess the reports, coagulation profile, then do a CSF. But antibiotics is something which you can give in the ER itself and should be given in the ER itself. Once you have diagnosed that patient is of meningitis, I'm clinically suspecting, this is the protocol. You start, maintain the airway. If you feel it is fine, then leave it. Then you treat with IV fluids, and then immediately ask the staff in order to give antibiotics at the first time. Also, you should in blood investigation should send all the routine CBC, electrolyte, LFT, renal functions. Along with that, if you are from an endemic area, you should always send malaria and leptospira also in these patients, if not dengue. There is no harm in giving the antibiotic stat dose 2 gram and on the clinical suspicion basis, rather than to wait for the reports and then giving. De-escalation we can do anytime.
Yes, sir.
Okay.
Sir, I have got one question. I was working earlier in 2011. There was our neurologist believed before giving antibiotics, steroids should be given. How much it is okay nowadays?
It's still the controversial. What happens? The idea behind giving steroid, the reason is whenever you give antibiotics, and especially it applies to tuberculosis, if you are suspecting tubercular meningitis and bacterial meningitis. At the time there was a theory that whenever you kill the bacteria in the CSF, whenever the antibiotic reaches the CSF and the bacteria are killed or tubercle bacilli are killed, they release certain inflammatory, means the debris of the bacteria and the tubercle bacilli causes intense inflammation in the CSF, which can worsen the meningeal signs, worsen the meningitis, not because of infection per se, but because of the inflammation part per se of the debris. So for that matter, they used to give steroid in the early phases, means 2 or 3 days they used to give steroids, but this is still controversial. Many people along with antibiotics they give dexamethasone, but as Dr. Benjamin is already told, it's more for pneumococcal meningitis, but it's also for tubercular meningitis, but it's not required in every case. But as a safer side, if you don't have any reports available or local flora, you can on the basis of seeing the brain imaging, if there is a large edema, very much edema, meningeal signs are very high, it's you can on basis of doubt start antibiotics along with low dose steroids in the initial phases, but giving steroid before antibiotics is not justifiable.
Okay, sir.
You may have patient in which you started the antibiotics, and though the antibiotics hit the bacilli and bacteria, but your symptoms worsen. So that is due to those killed debris which can intensify the inflammation. That's the thing.
Okay, sir.
So I think that was a very sweet short class, and we'll stop now. And next week we are not having any class because of Diwali. So happy Diwali and safe Diwali to all of you. Thank you for all for joining. Thank you, Dr. Benjamin. Thank you.